so now let's get on to the subject of what we are going to talk about today, which is ventilation perfusion relationship and its clinical significance. So if you want to sum up in one sentence the function of the lung, it would be just to take in oxygen from the atmosphere into the air, from the atmosphere into the blood, and to throw out carbon dioxide from the blood into the atmosphere. And this is done beautifully by the God-given lung. So essentially, the function of to create or to carry on this function of exchange of two important gases between the lung and between the atmosphere and the blood, you require air and blood to be brought into close proximity. And after that, the pressure gradients that exist will ensure that oxygen diffuses from the atmosphere into the blood, the pulmonary arterial blood, and vice versa. The carbon dioxide, which is in a higher concentration in the pulmonary arterial blood as compared to the alveoli, will now diffuse from the pulmonary arterial blood back into the alveoli. From there, it gets thrown out as we breathe out. Now, the basic functioning unit of all this is the alveolar capillary membrane. And I think this picture was already projected. So we shall just quickly go through this because you are familiar with this diagram. And it's a diagrammatic representation, of course. And what you see like a bell-shaped part of the picture on top is a representative alveolus. And what you see at the bottom, the red vessel that is at the bottom, is the pulmonary arterial or pulmonary capillary that is actually perfusing blood around every alveolus. And every single alveolus should ideally take part in gas exchange. But as you go along, as you go in depth into this class, you will realize that it actually doesn't happen. So there are a lot of physiological, anatomical, and pathological changes that happen in this ventilation perfusion relationship that bring about an alteration of gas exchange. So to start with the top left part of the diagram, it says tidal volume 500 ml. And I know this is very basic definition. Tidal volume is basically the amount of air we breathe in and out during a normal respiration. And if you consider that we are breathing at around 15 times per minute, the product of 15 times 500 gives us a value of what's called a minute ventilation, which is 7,500 ml per minute. Now, on the base, we know also from our days in physiology during MBBS and also reinforced by Anita's and Tushar's class that part of this, you can say roughly 30% of what we take in or 30% of the tidal volume actually goes as gas that fills the conducting pathways. And we will call that the anatomical dead space. And that amounts to about 150 ml. 30% of 500 ml is 150 ml. And it's only the remaining 350 ml that actually goes into the alveolus, which is a blue bell-shaped structure. And that's where the action is there for the lung. That's where the pulmonary gas exchange is happening. And if you multiply that 15 times per minute, we breathe 15 times per minute, multiplied by 350, we arrive at a value of 5,250 ml, and we shall simplify that to 5,000 ml or 5 liters. Now, when you look at the blood flow part, the red part of this diagram, that is the pulmonary blood flow, we know that cardiac output is the product of heart rate multiplied by the amount of blood we eject every heartbeat, which is called the stroke volume. So stroke volume times heart rate gives you the total blood flow per minute. That's the cardiac output. And for again easy calculation, if you take that 70 ml of blood is pumped out as stroke volume for every beat of the heart, and a heart beats roughly 72 times a minute, you get a value of 5,000 ml again. And we come down to now the basic equation between pulmonary blood flow and alveolar ventilation. And for ease of understanding and calculation, and also very close to the normal truth, the value is 1:1. 5,000 ml of alveolar ventilation is balanced by 5,000 ml of pulmonary blood flow every minute. Now, we must also remember that though the heart beats around 72 times per minute, we don't breathe. We should not be breathing at 72 times per minute. And therefore, if you take a ratio of the number of times we breathe to the heartbeats per minute, you find that we breathe about 4 to 5 times. Sorry, for every 4 to 5 heartbeats, we breathe one time. I correct myself. When we breathe once, the heart is already beaten 4 to 5 times. And therefore, we have come to the concept of what's called functional residual capacity, which is FRC for short, which is the amount of air that stays in the alveoli continuously and gets exchanged, the vitiated gases, carbon dioxide rich gas, oxygen depleted gas from the alveoli at the end of one breath, then washes all this out and replenishes it with more oxygen and less carbon dioxide containing gases. And this happens once for every 4 to 5 heartbeats. So this needs to be kept in the back of our mind. Now we come to the concept of what's called ventilation perfusion ratio. Very simplistically, we said that it is 1:1. We said that the ventilation per minute, alveolar ventilation per minute, a product of 350 ml of alveolar ventilation times 15, roughly 5,000 ml per minute, matches the 5,000 ml per minute of cardiac output, or 5 liters on one side and 5 liters on the other. And for those of us who've been trained under Dr. Fanindranath Tota, we must remember that when you put a dot on top of the V or a dot on top of the Q, what it means is minute ventilation and minute blood flow. So cardiac output per minute is Q with a dot on top, and ventilation per minute, not alveolar. If you add a letter A there, it becomes alveolar ventilation per minute. That is the VQ ratio. And we have now come to the conclusion that in an ideal situation, the VQ ratio should be 1. So now for efficient gas exchange to occur, ventilation perfusion should not only be matched, not only should it be close to the ideal alveolus, not only should it be close to a ratio of 1, but should also be equally distributed. And this probably, we will take 2 extreme examples to try and understand this. Imagine that you have intubated a patient, and unfortunately you have not detected that the tube has gone into one bronchus. And we know that essentially it normally goes into the right main bronchus more readily. And imagine that you passed a tube inadvertently into the right lung, and the left lung is not getting ventilated at all. The entire blood flow, the 5 liters of cardiac output, is now going to both the lungs. So essentially, if you look at the overall ventilation, it will be 5 liters per minute because you're ventilating only the right lung with 5 liters per minute. And the overall perfusion is also 5 liters per minute. And you look at the simple maths of it, it's a ratio of 1:1. And you would tend to believe that the VQ ratio is 1. But in actual fact, entire ventilation is going to the right lung, and practically 50% of the perfusion is going into the unventilated lung. So though apparently the VQ ratio looks like 1, you know that the left lung, which is not being ventilated, but which is being perfused, is now adding on to some kind of a ventilation perfusion mismatch. So when we say that an area is ventilated but not getting perfused, you call that dead space ventilation. And the other way around, when an area is getting perfused but not getting ventilated, you call that a shunt. And in this example, the entire left lung, which is getting ventilated, but so not getting ventilated, I correct myself, but getting perfused, is actually contributing to about a 50% shunt. Let's take another example. Again, it could happen. You could have a large embolus being thrown into the pulmonary artery. And let us now presume that your tube is in the right place. You're ventilating both the lungs correctly, but the large embolus has gone and blocked off one of the branches of the pulmonary artery. Gone and blocked off, let's presume, the entire main stem right pulmonary artery. So now you have a situation where the entire blood flow to the lung is going to the left lung. The right pulmonary artery is got blocked with a huge embolus, but the ventilation is going to both sides. So here you have a situation where the ventilation is happening at 5 liters per minute. The perfusion is also happening at 5 liters per minute, but the entire perfusion is going to the left lung. Again, at face value, it's a 1:1 ventilation perfusion ratio, but we know that when the right lung is not getting blood flow, the right lung is contributing to what is called a dead space. So these are extreme examples just to underline the fact of why we need to know of the small nitty-gritty changes that happen in health and also in disease that affect pulmonary gas exchange. Now, since we are talking about the ratio of ventilation to perfusion, it is ideal to break this up into two parts. One, to first look at how blood flow occurs, and then maybe the later part of today or tomorrow, we'll look at how the ventilation happens. So we'll first try to cover up the distribution of blood flow. Now, the total blood flow to all the organs in the body depends upon the cardiac output and the way the regional distribution is happening of this entire 5 liters per minute. Remember that the entire cardiac output has to pass through the lungs, okay, because it's a circuit that the right lung, I mean the right heart of the right heart has to perfuse the lung, and after getting oxygenated, the blood has to come back to the left heart, and then it traverses the entire body and supplies blood to all the other organs in the body. So the total blood flow to the lung is dependent on the cardiac output. However, the distribution of this blood flow, considering now all of us are possibly in the sitting position or reclining in our beds at home and listening to this lecture, but majority of us are sitting upright, and which is the normal position that most of us are in during a working day. So in that, you find that if you take the lung, which is the organ of importance for today's class, you find that the lung from the top to the bottom is roughly about 30 centimeters. And therefore, the blood flow at the bottom of the lung by sheer hydrostatic pressure is going to be much more than the blood flow at the top of the lung. And the difference is about 30 centimeters of water. And if you convert that into millimeters of mercury, that'll work out roughly about 4 to 5 millimeters of mercury. So there is a difference in the gravitational forces that act upon the blood flow in the pulmonary circulation. We know that the pulmonary arteries enter roughly at the hilum of the lung. So from there is a tendency for the blood to perfuse preferentially the lower part of the lung, because gravity aids the blood to go to the bottom of the lung in the erect position. Whereas if it has to go to the topmost alveolus in the lung, it has to play against gravity. It has to climb up from the hilum where it enters and then go up all the radicals of the pulmonary artery to the top of the lung. And eventually some pressure is lost, and therefore you can imagine that at the top of the lung, the gravitational effect will reduce the blood flow, and at the bottom of the lung, the gravitational effect will increase the blood flow. And this is what Sir John B. West very elegantly depicted in not only this diagram. Dr. John B. West is known for his probably best known for his treatises on ventilation, perfusion, and its relationship. So let me explain this diagram. You have this, on this diagram, you have 7 columns. The columns are the boxes that run vertically, and you have a total of 10 rows going horizontally. If you look at the topmost row, you have certain things written there, volume percent, V dot A in liters per minute, and so on. So that indicates what the number in that cell below represents. Now let's look at the 4 numbers that are there. There's a number 7 and 13 in purple or violet, if you're getting the colors right on your screen. And there's a number 0.07 and 1.29 in red, which again is supposed to indicate the blood flow. But what Sir John B. West did was he divided the lung into 9 slices. He theoretically divided the lung into 9 slices and imagined how much of the volume of the entire lung is there in each of these slices. So looking at the first column, the extreme left column, starting with the number 7, the topmost slice at the apex of the lung, the topmost of the 9 slices, accounts for 7% of the total volume of the lung, whereas the bottommost slice represents 13% of the volume, entire volume of the lung, right? So this only amounts to 20%, 13 plus 7, 20%. So the remaining 80% basically is getting distributed in the remaining 7 slices. You can imagine the numbers in between. But the important thing is, as we go from the top to the bottom of the lung, we see the shape of the lung. The lung is narrower on top and broader at the bottom. And therefore, it stands to reason that as we go from the top of the lung to the bottom of the lung, the percentage of lung tissue that each of these slices represents will increase, with the spectrum being from 7% on the topmost slice to 13% at the bottommost slice. Now we are talking about perfusion in the first part of this two lecture series. And now look at the number 0.07. 0.07, what does it stand for? It stands for Q dot in liters per minute. So what that means is, it means 0.07 liters per minute is the blood flow to the topmost slice of the lung. In contrast, the bottommost slice gets 1.29 liters per minute as the blood flow per minute. Okay, so you can easily understand that gravity has pushed much of the blood flow to the bottommost slice of the lung. Now we need to look at not just the absolute numbers, but if we were to calculate the amount of blood flow per percent of lung volume, what you need to do is divide 0.07 with 7. Again, very easy maths. You get a value of 0.01. 0.07 is the 0.07 liters per minute in 7% of the lung volume, and therefore in 1% of the lung volume it would be 0.01 liter per minute percent of lung volume. A similar math at the bottom, assuming that this is 1.30 instead of 1.29, a simplification, you will get a value of 1.30 divided by 13, which gives us a value of 0.1. So it's 0.01 liter per minute per percent of lung tissue at the top of the lung, and 0.1, exactly 10 times that much, 0.1 liter per minute per percent slice of per percent of lung tissue at the bottom of the lung. So this is entirely because of the gravity. So the first fact we need to remember is that blood flow per unit lung volume is 10 times more at the base of the lung than it is at the apex of the lung. Not just because of the gravitational effect. As we go along, we'll realize that there are some more factors that play when we are talking about the pulmonary circulation, and I shall try and elucidate that as we go along. So first thing you remember is that at the bottom of the lung, the blood flow per unit per percent of lung tissue is 10 times as much at the bottom as compared to the top of the lung in the erect position. I'm now going to complicate this class further by introducing other positions, but at this point I'd like to say that most of our anesthetics, okay, are given in the supine position. Most of our patients in the ICU are in the supine position, and in the supine position you'll find that most of our lung is actually very well perfused from back to front, and the topmost portion of the lung, which is seen in the erect position, doesn't really play a big part in a supine position, or in the prone position for that matter, or in the lateral position, which are all the positions in which we anesthetize our patients, or we sometimes place our patients in the ICU for various reasons. The topmost slice of the lung receives 1/10 the blood flow as the bottommost slice of the lung per unit lung volume, and this is indicated diagrammatically here by this red line. To the right of the x-axis, you find is written top or the rib number. So rib number 1 or the top of the lung is to the right side of this x-axis, and to the left, as you go along the left x-axis towards 2, 3, 4, 5 at the top of the lung, you're actually reaching the topmost slice, the bottommost slices of the lung. So taking this line, we said at the bottom, at the top of the lung, we said 0.07 divided by 7, we got 0.01 liter per minute per percent lung volume. And that, if you extrapolate this line, will be roughly around that. Okay, not very accurate. 0.01 liter per minute per percent lung volume. And at the top, it is around 0.1 liter per minute per percent lung volume. So all this diagram depicts again is in actual numbers the fact that from the top to the bottom of the lung, the blood flow increases. Now, why does this distribution of blood flow change? It changes because in any organ, you look at any organ, the blood flow through any organ or any pipe for that matter, or any blood vessel for that matter, will depend upon the difference between the entry point and the exit point of that particular pipe. When you look at the kidney, for example, or you look at the liver, for example, it is the arteriovenous pressure difference that creates the pressure differential for the blood to flow through that organ. Let's take the renal perfusion as an example. So the renal arterial pressure minus the renal venous pressure will give you the perfusion pressure of the blood that is going through the blood vessels. And of course, we have local factors that constrict and dilate these vessels, and they manipulate the arteriovenous pressure difference depending upon the needs of the patient at that particular point of time. So the basic tenet is that for blood flow to occur across any organ, it is the arteriovenous pressure difference that creates this ability for the blood to flow from the arterial side to the venous side. Now, why is the pulmonary circulation different? The pulmonary circulation is slightly different because there is another factor that comes into play. Not only is the pressure difference between the pulmonary artery and the pulmonary vein that is important to drive this blood across the pulmonary capillaries, but also there is an alveolus that is there. And if you take the entire lung, there is an airway pressure within the alveoli that acts like a pinch cock on these blood vessels. It is, for easy imagination, imagine you have an IV fluid bottle hooked up to a patient and you flow controller of the IV fluid completely open, right? This is how blood flow occurs through every tissue in the body with the exception of the pulmonary circulation. The higher the bottle is on the IV stand, the higher is the arterial perfusion pressure, and the lower the venous point, that is the point of entry of the IV fluid into the body, the lower that is, the greater is the perfusion pressure. So what do we do when a fluid doesn't flow? We raise the fluid bottle. We increase the hydrostatic pressure. We increase the arterial pressure, so to say, so that more blood flows through these systems. Now, in the pulmonary circulation, there is an alveolar pressure that also comes into play that influences the distribution of blood flow. The first fact we learned was that the blood flow occurs through any organ, including the pulmonary circulation, depending on the arterial to venous pressure difference. We also realized that in the erect position, the blood flow to the lung is much more per unit lung volume at the bottom of the lung as compared to the top. And we need to remember this factor of 10. It's 10 times more per unit volume of the lung at the bottom of the lung as compared to the top. And now let's see how alveolar pressure creates another factor for us to understand as to how blood flow occurs in the pulmonary circulation. So we have three pressures: pulmonary arterial pressure, which is abbreviated as PA, pulmonary venous pressure as PV, and alveolar pressure as P subscript A, but a capital A for a difference. Okay. Now this is what Sir John B. West described many years ago, and it's known by the name of West's three-zone model. So let's look at this West three-zone model. Some of the ardent readers of respiratory physiology will now say that there's a fourth zone that is added on. But for our class today, it is sufficient if we understand these three zones properly. Now let us look at the topmost slice. Let's look at this portion where the arrow is pointing. Now this is the maybe top two slices of Sir John B. West's model, theoretical model. What is happening here? If you look at the left side of the blood vessel, okay, that's where the pulmonary arterial flow is coming in. It's written as PA there. So pulmonary arterial blood is coming in here, and pulmonary venous blood is exiting from this alveolus, possibly after complete oxygenation and removal of carbon dioxide. But what is happening to this blood vessel right in the middle? It is getting pinched, much in the same way as if you have completely closed down the control tap of your IV fluid system. So irrespective of at what height the IV bottle is, no fluid will flow into the patient because the pinch cock is completely closed. And that's what is the additional factor factored in by the alveolar pressure. If the alveolar pressure is very high, then what happens is in what we call zone 1, the P capital A alveolar pressure is higher than the pulmonary arterial pressure, which in turn is higher than the pulmonary venous pressure, and this West referred to as zone 1. And in this, though the arteriovenous pressure difference eventually determines how much blood flows through the particular slice of the lung, the alveolar pressure will determine. If the alveolar pressure happens to be higher than the pulmonary arterial pressure, then no blood will flow through this particular alveolus or this particular lung slice, and this particular lung slice will only get ventilated, will not get perfused, and will contribute to what we call dead space ventilation. I know that Tushar and Anita went into a lot of detail of calculating dead space and the shunt fractions and things like that. But I was just wishing that this class had come before that, so that the concepts that they tried to project would have come out easier. So zone one, which is above the first dotted line, is a zone where the alveolar pressure is higher than the pulmonary arterial pressure, which in turn is higher than the pulmonary venous pressure. And the blood flow through this zone is determined by the interplay between the pulmonary arterial pressure and the alveolar pressure. Whichever is higher will determine how much of blood flow occurs through this particular uh, zone. Now let's come to the middle slice. Now the middle slice is centered around the hilum, as you can see, and the middle slice is what is called zone 2. Now in zone 2, the Pinchcock effect, as you can imagine or you can see from the diagram, what is almost completely closed here is now slightly opened up. That's because the hydrostatic pressure has now increased at the hilum. So at the hilum, the blood flow comes in. The pulmonary arterial to venous pressure is still there. However, the alveolar pressure now becomes less significant. So PA, which started the relationship in zone 1, has now moved to second position. P capital A has moved in between pulmonary arterial and pulmonary venous pressure. So now pulmonary arterial pressure is now slowly gaining the upper hand. And as you move down this zone, as you move down from the top to the bottom of zone 2 and gradually approach zone 3, the pulmonary arterial pressure will keep increasing, surely because of hydrostatic pressure. And that's the reason why this diagram to the right says, as you move down the distance of the lung, you find that the blood flow increases. Above the first dotted line, just for understanding, there is no blood flow. When we reach a point when the pulmonary arterial pressure exceeds the alveolar pressure, blood flow starts. And that is what is indicated by the start of blood flow. And as you go down zone 2, you find that the blood flow increases from the top to the bottom of zone 2 as well. Right. So in zone 2, the interplay of factors is pulmonary arterial pressure is more than alveolar pressure, which in turn is more than the pulmonary venous pressure. So alveolar pressure is now playing a less significant part. However, it is playing a part in the amount of blood flow that's occurring through zone 2. Let's look at zone 3. In zone 3, you find that the hydrostatic pressure is so huge that the blood vessel, which is lying in close proximity to the blue alveolus, is now distended. It has got recruited, almost to say, it has become distended. So the pulmonary arterial pressure is definitely more than the pulmonary venous pressure, but the alveolar pressure now ceases to play any role at all in controlling the blood flow through zone 3. It is only the interplay between the pulmonary arterial pressure and the pulmonary venous pressure. And both these pressures are pressures within a blood vessel. And therefore, as you move from the second dotted line downwards, you find that because the hydrostatic pressure increases from this point towards the bottom of the lung, the hydrostatic pressure will increase, right? Because we are going down to the bottom of the lung. It's like a pipe. At the bottom of the pipe, the pressure increases, but it increases to a proportionate extent in the arterial as well as the venous blood. And therefore, as we go down this zone, the blood flow increases, not because of a difference between the pulmonary arterial and the pulmonary venous pressure, not because of an interplay between these pressures, these blood pressures, arterial venous pressures, and the alveolar pressure, but because of the fact that the hydrostatic pressure in both these vessels is being increased. And as a result of this, zone 3, we go from the top of the junction of zone 2 and 3 to the bottom of zone 3, the blood flow increases with the alveolar pressure now moving to the third spot in our equation. The alveolar pressure now plays hardly any role or no role at all in determining the blood flow through this particular segment of the lung or the bottommost slices of the lung. I think this is a very important concept to understand, and therefore that's why I spent a little more time in this. So you have zone 1, zone 2, zone 3. For some of the beginners in anesthesia who find this difficult to understand, I used to always say that imagine that arterial pressure, you don't have to imagine that, arterial pressure is always higher than venous pressure, and alveolar pressure just moves, when you move from zone 1 to zone 2 to zone 3, moves from position 1 to position 2 to position 3, with pulmonary arterial pressure always exceeding pulmonary venous pressure. Now in zone 1, just to sum up, it is virtually absent under circumstances. Okay, that's the beauty of the body physiology. Is made in such a way that even in the erect position, it's only the topmost part of the topmost slice of the lung that probably lies in zone 1. But there are some pathological conditions in which this plays an important role. And this is important for us to know because our patients get hypovolemic, they get hypotensive during surgery because of blood loss. We get hypotensive and hypovolemic patients coming for care in the intensive care unit. We definitely use PEEP to improve oxygenation, both in the operating room as well as in the ICU. And these definitely have an influence on the blood flow through zone 1. Hypovolemia and hypotension will both reduce the pulmonary arterial and pulmonary venous pressures. Okay, so alveolar pressure now tends to play a much bigger role in hypovolemia and hypotension. So zone 1 will start making its appearance if your patient is hypovolemic or hypotensive. And if you add on PEEP in that situation, it will become even more significant because PEEP essentially increases the alveolar pressures. So you are increasing P capital A, and therefore PEEP increases P capital A, hypovolemia, hypotension decrease the pulmonary arterial pulmonary venous pressures, and therefore these three pathological conditions can result in an increase or the appearance of zone 1 in an individual. Now, blood flow increases as we move down from top of zone 2 to the bottom of zone 2, easy to understand. Coming to the bottommost zone, as you saw in the earlier picture, I'll go back to that again. You find that here, in the lowermost diagram of the alveolus at the pulmonary artery, you find that the artery has got distended. It's like an M shape on top and a W shape below. But essentially what it's trying to show is that vessel has got distended. And this vessel has got distended because of the hydrostatic pressure within the vessel being far in excess of the alveolar pressure. And therefore, blood vessels are distensible, they get distended. And that's the reason why we get a decrease in the vascular resistance and what we call capillary recruitment as we go to the bottom of zone 3. From the top of zone 3 to the bottom of zone 3, blood flow increases. And also at a point you start getting capillary recruitment. Some of the capillaries that were lying lazy, not working, now start working, they get recruited and they start taking part in gas exchange. We finished the distribution of blood flow, and now I thought we'd just get an introduction to the distribution of ventilation. So now looking at the ventilation part of it, when you look at the size of the lung, because the heart occupies a part of the left thoracic cavity, the left lung is marginally smaller than the right lung. And therefore you can say, we are all very fond of numbers. Numbers also help us to understand concepts. So you can say that the right lung is contributing to about 55% of the total lung volume, whereas the left lung is contributing about 45%, together making up the 100%. Excuse me. Right. So the right lung, in comparison to the left lung, occupies 55% versus 45% of the total lung volume. Now, let's go back to Dr. Faninana Thota's classical example of a catapult. He used to explain beautifully about cardiac physiology, or basically about any muscle physiology. When you stretch an elastic structure like a rubber band or a catapult band, then you release it, the distance that your object goes to will depend upon the amount of stretch you have created in the catapult. And this is what in cardiac physiology is known as the Frank-Starling's law. The more the blood is filled into the ventricles at the start of systole, the more the stretch of the ventricular muscles at the start of systole, the stronger will be the systolic contraction within physiological limits. Now that's Frank-Starling law for us from cardiac physiology. Now extrapolate that into respiratory physiology. And what do you see? If, as I said, most of our patients are anesthetized in the supine position. In the supine position, because of the weight of the various the abdominal organs pressing on the posterior part of the two hemidiaphragms, the posterior part of the diaphragm gets stretched because of the mechanical effect of organs pressing upon the posterior part of the diaphragm as compared to the anterior part of the diaphragm. And as a result, the increased stretch of these muscles will ensure that the posterior part of the diaphragm in a supine position will contract more efficiently, okay, as compared to the upper part of the lungs. And this may be true in the lateral position also. If you have a patient in the right lateral position, the right hemidiaphragm gets pushed up much more as compared to the left hemidiaphragm, and therefore the right hemidiaphragm will contract much more effectively. So what does this result? If the basal portions of the lung, which is closest to the diaphragm, will will effectively be expanded to a much greater extent depending upon their proximity to which part of the diaphragm is contracting more efficiently. And that's what is summarized in this particular slide here. It says cephalad displacement of the diaphragm in the dependent portions of the lung results in better ventilation due to greater resting fiber length. And that is irrespective of the position of the lung, which is sometimes the reason why, or not sometimes, which is definitely the reason why we think of bone position ventilation and things like that in ICU to improve ventilation to those parts of the lung that were lying dormant for some period of time. I'm just trying to relate physiology to pathophysiology so that, as we go along, we understand why we are doing certain things in anesthesia, and that definitely makes our practice of anesthesia and intensive care much more scientific. So going back to this diagram again, so John B. West's 9-slice diagram, we now concentrate on the second column where certain numbers have come up. 0.24 is the alveolar ventilation per minute, okay, in liters per minute in the topmost slice of the lung, whereas in the bottommost slice of the lung, which is volumetrically bigger than the top of the lung, it's 0.82 liters per minute. Easy to understand. If more lung tissue is there at the bottom of the lung is fatter than the top of the lung, obviously it gets the lion's share of the ventilation at the bottom of the lung, right? So we're looking at absolute numbers of 0.24 liters per minute, okay, of alveolar ventilation to the top slice, and to the bottom slice is 0.82 liters per minute. Again, I would like you to do this math, and I have already written this down in a piece of paper for my, so I can quickly tell you these numbers. If you were to divide 0.24 by 7%, again, to arrive at a value of alveolar ventilation in liters per minute per percent of lung volume, you'll get 0.24 divided by 7, which is a value of 0.03. It actually goes on to some more decimals, but for us, I think we'll just stop at the third decimal. 0.034 is the number I got. Similarly, when you divide a 0.82 by 13, I got a value of 0.063. So if you look at this, 0.034 on top, or I'll make it even simpler, 0.03 liters per minute per percent lung volume, 0.06 liters per minute per percent lung volume at the bottom. Just look at the numbers now, 0.03 on top and 0.06 at the bottom. We have come to the conclusion that ventilation also is much more to the bottom of the lung, but not in the same proportion as we saw for blood flow. While blood flow increased in a factor of 1:10, the ventilation is increasing in a factor of 1:2 in terms of absolute values. We're familiar with this diagram. The diagram depicted to us how the blood flow increases from the top to the bottom of the lung. Again, just to revise, the rightmost part of this red line starts at roughly around 0.01. Okay, it's a little wrong. You should have probably gone a little further down. Should be roughly around 0.01 liters per minute per percent lung volume blood flow. At the top, it should be 0.1. So let's superimpose upon this the ventilation, and that's what we see. The ventilation also, as depicted by the blue line, increases from the top of the lung to the bottom of the lung. But as you see, the slope is much less steep. And therefore, if you actually were to extrapolate the bottom or the rightmost part of this line, will come to 0.03, and the upper part will come to 0.06. So essentially, the ventilation is twice as much per unit lung volume at the bottom of the lung as compared to the top, while the blood flow is 10 times as much at the bottom of the lung as compared to the top. And now these relationships will be unfolded when we start looking at ventilation versus perfusion as a ratio. Because essentially, as we said at the beginning of the class, it's not enough if you have a total ventilation that is adequate and a total perfusion that is adequate. What you need is an absolutely balanced ventilation to perfusion ratio, which is what we call an ideal alveolar to ideal ventilation perfusion ratio, which we see only in the ideal alveoli, and that is where gas exchange happens effectively. Now, if somebody were to ask you, I know all these terms were again introduced thankfully by Anita and Tushar, they talked about airway pressure, they talked about intrapleural pressure, they talked about alveolar pressure, they talked about pressure gradients between the mouth and the alveolus, the mouth and or the alveolus and the pleura, the alveolus and the outside of the body. All these have got certain names in respiratory physiology. So we shall concentrate only on two terms. Intrapleural pressure, simple enough. It's the pressure within the pleura. And if you were to be asked as a postgraduate, what is the value of this? You just need to say it varies from -5 centimeters of water to +5 centimeters of water. But to understand why the ventilation changes from the top to the bottom of the lung, we need to split this up into a little better understanding. When you look at the top slice or the top portion, here again you have number of dots here, okay? Number of dots have been indicated to show different alveoli. At the top of the lung, you have a value written as -10 centimeters of water. And at the bottom of the lung, it has got a value of -2.5 centimeter water. And if you were to take the middle point of this, you will get a value of -5 centimeters of water. Or maybe not that, it's about 7 point, it will come to a little more than that. Okay, now look at the height. The height of the lung from the top most portion of the lung to the bottommost portion of the lung is 30 centimeters. So in most average adults, from the top to the bottom of the lung, it is 30 centimeters in actual height. And when you look at the density of the tissue, because it's air filled, it's not like the liver, which is hard, which is solid. The lung is an air filled organ, and therefore the density is only a variable of it's 0.25 centimeter per actual centimeter of height. So for a distance of 30 centimeters, the difference is only 30 divided, it's 1/4 density, so to say. So you divide 30 by 4, you get a value of 7.5. And that's the reason why you have a difference of 7.5 centimeters of water from the top to the bottom. Now, somebody looking at the slide very carefully may ask, why is it -10 at the top and -2.5 at the bottom and not the other way around? And for that, I will need to explain by using this picture. Now, imagine that the lung is like a fluid filled bag. Okay. If you hold up a plastic bag filled with water, you'll find that the top, the point where you're holding, the neck of the plastic bag will be narrow, whereas the bottom of the plastic bag will swell up because the weight of the water distends the bottom of the bag. The lung is very much like that. If you were to hold up the lung by the trachea, so to say, the lung will fall away from the chest wall. And as it falls away from the chest wall, again, I don't know whether Anita and Tushar emphasize this or any previous class emphasized this. Remember that the FRC is the resting position at which the total inward pull of the lung, elastic lung, is equal to the total outward pull of the thoracic cage. So essentially, when you look at the system in balance, the thoracic wall is springing outwards and the lung is springing inwards. And because these two structures are going away from each other, a negative pressure is created within the pleura, and this is what is called the intrapleural pressure. Try and cover up any question that might come up from today's class tomorrow. So my email ID is there, and I think I shall stop with this, Manjana. Thank you.